LVRS is clearly the gold standard for treatment. I'll explain why. Really, we're talking about risk versus benefits. We know what risk looks like, and that's what benefits looks like. So what are the benefits of the endobronchial valves? Now, we have a randomized trial, the VENT study. We have Eurovent as well. And you have to admit, overall, there was very little, there may be statistically significant benefits in the VENT trial, but they weren't judged to be clinically relevant, and so the US FDA did not approve the use of valves. These guys know what they're talking about. There were small benefits. Yes, they were refined such that if you could get lobar exclusion, you got better benefits. And this is an important point to remember, that it's all about patient selection. There's no long-term safety data on valves, but in the VENT trial there was an excess of serious complications over the control arm. There was pneumonia, there were exacerbations of COPD. 1 in 7 patients had their valves removed within a year, and Sri and I have both seen examples where the patients have coughed up their valves. And the pneumothorax rate is somewhere between 10 and 20%, not always clinically significant. So they're not without risk. The coils, again, we're going into more experimental techniques. The RESET trial, all credit to Pala for doing this trial, but there were small benefits. There were very few early isolated serious adverse events, and there was no mortality, as we've seen. But one cannot exclude a significant placebo effect. Very eminent pulmonologist said that in a recent article, Dr. Shah from the Brompton. So the largest trial of thoracic surgery of any kind was the NETT trial, the North American Emphysema Treatment Trial. It had its flaws, the method of volume reduction, the number of centres that were involved, maybe diluted the quality of the results. But there was no getting away from the fact that this actually proved in a randomised controlled trial that volume reduction surgery had benefits in terms of quality of life and survival in some patients against best medical care. So this is a proven treatment for end-stage emphysema in patients that have reached the end of medical therapy. And again, it's important to focus on the patients that will benefit most from this treatment. The patients with upper lobe predominant emphysema, low exercise capacity, had an increased survival. And the benefits were long-lasting. This trial's now had the opportunity to review the long-term data. There was a survival advantage that lasted for 5 years, and in those upper lobe predominant patients with low exercise capacity, the survival improvement lasted for 5 years. The exercise improvement was durable, as was the symptom relief, the health quality of life improvement. Even in those with high exercise capacity, there was no survival advantage, but there was a durable benefit in exercise capacity and quality of life. So this is a proven, has proven benefits in a randomized controlled trial that are durable. And these are the results you all can see. So sustained improvement in exercise capacity up to 3 years after randomization, in quality of life up to 5 years after randomization, and from baseline FEV1 and 6-minute walk, you can see durable benefits, and also the magnitude of benefit in terms of FEV1 was something like twice the benefit that the endobronchial treatments can give you. So it's even been reported that you get a 50% improvement in FEV1 in some of the early volume reduction operations. And I'll come on and explain why I think that's why. The reason that you guys are scared to do LVRS in your centres, particularly you newly appointed thoracic surgeons, is you don't want to have your patients banged up on intensive care for 2 weeks on a ventilator. That's why you don't do it. That's why you've been persuaded by these merchants with the valves that this is an easier, lower risk option. And yes, if you decide to do LVRS on high risk patients, you will end up with that scenario. And Mr. Ratnam and myself have been there. We've done those Saturday morning ward rounds on intensive care, scratching our chins while the patient after LVRS is on a ventilator. But it depends who you decide to operate on and what you think the perceived benefit is going to be. And the LVRS, the NETT trial, created a lot of waves because they rapidly produced this publication that said there was a patient at higher risk of death after volume reduction surgery. Now, those illiterate thoracic surgeons that couldn't actually read the paper just read the headline and read it that all patients were at high risk after volume reduction surgery. And that was disseminated down to the physicians, and that's why you don't get referred the patients. However, the current UK risk is a lot less than that. The Brompton, the highly selective practice in the Brompton, but it's still in 81 procedures with an MDT approach, have reported 0 90-day mortality. We've been a little bit more aggressive in Glenfield, and we've done more procedures because we've spread the net into higher risk patients, but we're still running about a mortality of 3 to 4%, even in these high-risk patients, and some of them are transplant candidates. In fact, a large proportion would fit the transplant criteria. We've been able, because we've done over 300 procedures now, to calculate our own risk adjustment and risk stratification based on the predictors you'd expect, BMI, transfer factor, and FEV1. So we can now predict and estimate for the patient what the risk is going to be of their operation, which is useful to give them informed consent. And if you look at the 3 big groups we've got, the high-risk group, transplant candidates, their 30-day mortality, yes, is 15%. But these are patients that are right in the end stage. They're just about transplant candidates. But if you look at the low risk, nearly over 100 patients now, there's no 30-day mortality, and there's been 1 death in a year. So if you look at there's still end-stage emphysema patients, but the lower risk category, you get significantly higher benefits than valves and low mortality. And it's all about fitting the treatment to suit the patient. There are limitations with valves. We found them. This, for example, is a patient. Now, we know about the limitations of collateral ventilation. A number of patients you hope will be suitable have collateral ventilation. You can't put a valve in. We've seen delayed collateral ventilation, where initially the X-ray has shown volume reduction in the lobe, but over time the lobe is reinflated. And we assume that there may be opening of these collateral channels with the change in ventilation of the lungs. So we don't fully understand the mechanism of collateral ventilation, but it's possible there are these potential channels that open up as the lower lobes get more ventilated. And what you see here is what we've just seen is compensatory hyperventilation of the remaining lung. So this left upper lobe valve, put in by a member of this audience, a trainee, worked perfectly. It collapsed the left upper lobe, but the patient got worse. Because what it's done is diverted all the ventilation into the more compliant right upper lobe. And you can see there that the oblique fissure on the right has actually been pushed down. So what's happened is the patient's, obviously the right upper lobe is still the most compliant part of the lung, and so all the ventilation has gone to the right upper lobe. So the mechanism of action, the reduction in volume of the chest wall, the improvement in chest wall mechanics, has not occurred because the patient's just redistributed the ventilation. Now, in volume reduction surgery, what you do is you don't block out the entire lobe, but you leave the less compliant, more normal, elastic part of the lobe. So you won't get all the redistribution to the more compliant contralateral lung. If this physiology is too much for you, then Kalev will explain this at the end, okay? The limitations of coils. We don't know what it means, the selection criteria in terms of excessive lung destruction. At the moment, when we took a number of cases to Germany, to the experts in coils, and said, would you put coils in these patients, would you put valves in them? And there was some hocus pocus going on. Looking at the CT scans, they said, this is too bad, this is not too bad. There's a subjective assessment of the morphology of the emphysema, which we need to drill down on to select those patients who are going to benefit most. Initially, they selected the patients with a higher degree of hyperinflation. That has been relaxed now. But importantly, there's been a significant waning of benefit. There's no durable benefit from the coils, as far as we know at the moment. Nothing like the benefit from lung volume reduction surgery. And yet, we still don't know how these coils work. Palav's got this idea that it may improve elastic recoil, and it's an attractive suggestion, but there's no physiology to back it up. Whereas in volume reduction surgery, there is clear physiology of improvement in chest wall mechanics. It's probable that they work in a different way. So, in conclusion, LVRS has clearly been shown to improve outcomes. The morbidity and mortality in the NETT trial is likely to be lower than in current practice. And with appropriate selection in the right hands, the risks of LVRS can be minimised. And it's true to say that before we get on board with endobronchial valves, there needs to be randomised trials of endobronchial valves against the gold standard of volume reduction surgery before widespread use can be recommended. Now, Palev's nodding his head in acknowledgement of these, and he should do, because he said these things. So, importantly, you all need, as thoracic surgeons, to have an LVR toolkit. You need to be in LVR MDTs. You need to have a toolkit that includes coils. It includes valves. But the gold standard is surgery, and that has to be the first option. And I do agree with Palev, and a statement he made recently in one of his publications, that the challenge is to determine those patient characteristics that predict the response to each individual technique. Let's individualize the patients to the technique. It's not a competition. We want to be treating many more patients. This is the growth industry in thoracic surgery. You guys need to be surgical physiologists. Okay? It's a very exciting field of this discipline. And yes, endobronchial volume reduction may be the new kid on the block. It's the Manchester City of respiratory medicine. They've invested a lot of money in it. They've been flush with recent success. That's true. But like Jose, the surgeons know who are the real special ones.
That was brilliant, David. I really would like to discuss this, but I think we get strangled by the technicians.